Hi, everyone. Welcome to the All Things Amyloid podcast, where we feature patients, caregivers, and clinicians who discuss amyloidosis, a rare and incurable disease. Amyloidosis occurs when the body builds up abnormal amounts of misfolded amyloid protein, which can lead to serious and life threatening outcomes. I'm your host, Mackenzie, an amyloidosis patient and founder of Mackenzie's Mission. Our goal for this podcast is to raise awareness and share firsthand what it's like to live with this disease, to care for those affected by it, and to treat it. We hope this leads to earlier diagnosis and start of treatment, which will improve patient lives. In the last handful of years, really since the FDA began approving therapies for amyloidosis, experts have increasingly begun shouting that the biggest challenge surrounding this disease is now lack of awareness. The historical view of amyloidosis from the 1990s was that because there was nothing providers could do for patients, that there was little motivation to look for it. Well, that's now an outdated view and also simply wrong. As a result, there are growing efforts to raise awareness, whether that be through publications of research and findings, conferences, webinars, and education and medical school curriculums, as well as residency and fellowship program didactics. In this episode, we'll hear from Dr. Justin Groden, a cardiologist and co director of the UT Southwestern Multidisciplinary Amyloidosis Program. Adapted from his video, Building an Index of Suspicion for Cardiac Amyloidosis, Dr. Groden discusses early symptoms, family history, and red flags to be aware of in order to build a clinical index of suspicion for cardiac amyloidosis.
Hi, everyone. My name is Justin Groden. I'm a cardiologist and heart failure specialist, and I also co-direct the amyloidosis program at UT Southwestern. This short talk is going to be discussing how we build an index of suspicion for cardiac amyloidosis. I have a number of disclosures, and they're displayed on your screen. The outline of this discussion is really we have three key points. We're going to be discussing the natural history of cardiac amyloidosis red flags, and then we will briefly talk about some diagnostic tools that are useful that increase our index of suspicion for diagnosing this disease. So I think it's really important as we think about red flags or clues or building an index of suspicion for diagnosing this disease is that we recognize that this disease has really a long indolent phase, or really a preclinical phase, that is building up to the point where we see these patients. Now, if you look at this cartoon on this slide, it really demonstrates that myocardial infiltration, as displayed in the light blue curve, really is a progressive process. And it really isn't until we start to see that people are symptomatic, or maybe even in the pre-symptomatic phase, that we see their cardiac biomarkers go up, natriuretic peptides, cardiac troponins. And then, of course, in the symptomatic phases, we see decline in functional status, quality of life, and we also see increase in hospitalizations until death. Now, unfortunately, the majority of our patients are diagnosed in the symptomatic or advanced stages. And so hopefully some of the clues that I discussed during this discussion will help us diagnose the disease earlier. So one key clue when we're thinking about diagnosing cardiac amyloidosis is really, what is the patient's family history? Now, of course, there are, at least we think there are approximately, there are 11 types of cardiac amyloidosis. However, the overwhelmingly over 95% of all cases are either AL or ATTR. As a result, it's really important to ascertain a family history. In particular, if we have a patient in front of us that has African ancestry. Now, this could be an African American, a Black individual, or an individual that is of Hispanic ethnicity, but also has African ancestry. Why is this important? Because these individuals may uniquely be at risk for developing ATTR. So really putting the importance on a family history. And 2 to 4% of African Americans in the United States and all throughout the world carry a mutation, the V122I gene, that puts them at risk for having this disease. So what about some other common clinical scenarios? Now, these are more specific for ATTR, but some of them are shared by AL amyloidosis. So anybody that is hospitalized with HFpEF, we do see that approximately 13% of those individuals may have cardiac amyloidosis. Anybody that is referred for TAVR, that is transaortic valvular replacement, and for aortic stenosis, approximately 12% of these individuals may have cardiac amyloidosis. And then, of course, anybody with carpal tunnel syndrome who's had a carpal tunnel release, we know that the tenosynovium of these individuals may stain positive for amyloidosis, and that's either AL or ATTR. But we've also seen that amyloid staining can also be positive in a number of other non-cardiac clinical scenarios. In particular, lumbar canal stenosis, rotator cuff tears, and a traumatic biceps tendon rupture. These tend to be a little bit more specific for ATTR amyloidosis. So what about some red flags or clues when we're seeing these individuals? And I think what's really important when we think about these, a high index of suspicion is really mandatory. The disease is not that challenging to diagnose, but really what the key hurdle is establishing that threshold where you are thinking about this disease. And now some of these clues can be these clues rather, can be quite useful. So I think it goes without say, but anybody with unexplained LVH on echo. Now, we know that amyloidosis is really not LV hypertrophy. Rather, the ventricles are thick largely because of intramuscular deposition of amyloid fibrils. But if you are seeing a patient that has a really thick myocardium or thick ventricles on echo, but they don't have a history of hypertension, this should serve as a really strong clue that this individual might have amyloidosis. And then I think this one really goes without saying, anybody with an unexplained restrictive cardiomyopathy. So if you're not a cardiologist, you'll have to look at the echocardiographic reports or really have a cardiologist tell you that this is what's going on. But anybody with an unexplained restrictive cardiomyopathy should be considered to have a diagnosis of cardiac amyloidosis. And as I mentioned before in the prior slide, anybody with a history of carpal tunnel syndrome, bilateral especially, there have been a number of studies that have demonstrated that really within the 5 to 10 years prior to diagnosis, and this is either before AL or ATTR cardiac amyloidosis, that these individuals can have administrative coding diagnoses for carpal tunnel syndrome. And then this is rather specific for ATTR, but as I mentioned before, atraumatic biceps tendon rupture. This should really be a red flag, and it might be more specific for ATTR amyloidosis. I also have a number of patients that have had Achilles tendon ruptures as well. Anybody with an unexplained neuropathy. So for example, if somebody has a sensory and motor polyneuropathy or an autonomic dysfunction, this should be a strong clue that they might have amyloidosis, because we can often see a neuropathy paired with cardiomyopathy, and we can see this in both AL and ATTR amyloidosis. It should also raise a red flag if you have a patient that has diabetes, but their diabetes really is not that severe, or it's well controlled, and then this neuropathy really is disproportionate to what you would otherwise expect. And, really related to that, I think anybody with orthostatic hypotension. So really what this is that somebody that gets really, really hypotensive, their blood pressure is low when they go from laying down to sitting or to standing. I have a patient that her orthostasis is so severe that her blood pressure is not measurable for 10 to 15 minutes when she gets up in the morning. And this is a clue that there is an autonomic neuropathy. And then this is evolving, but anyone with a hypertrophic cardiomyopathy that is diagnosed later in life after the age of 60. So this picture just demonstrates what an asymptomatic biceps tendon rupture looks like. And you can see that there looks like what appears to be a Popeye's bulge in the distal aspect of the upper arm. So we have a number of diagnostic tests that are really not amyloid type specific, but they can increase our index of suspicion. We have echocardiography, ECG, and cardiac MRI. Again, these are essentially tests that lead to another test. So this is the classic ECG of a patient with cardiac amyloidosis. And you can see that if we look out to the limb leads, they are dominated by very, very low voltages. And if we look at the precordium, V1, V2, V3, and so on, we see that it looks like they had an anterior myocardial infarction or a prior heart attack. So as I mentioned, the classic presentation is we see that LVH on echo, and then really this can be paired with a low voltage on ECG. And I'm giving you some classic parameters here in the bullets on your screen. But this ECGs do have pitfalls. They're not type specific. Only about half of all individuals with AL meet criteria for meet the low voltage meet ECG criteria for cardiac amyloidosis. About a third with ATTR meet this criteria, and only about half have this pseudo infarct pattern in the precordium. So in general, an ECG without classic features does not rule out cardiac amyloidosis. Now, what about cardiac MRIs? So I think MRIs are really, really useful tools. This is a classic image of a patient with ATTR wild-type cardiac amyloidosis. And what you're looking at are the contrast-enhanced images. So if you look at the white splotches, those are areas of late gadolinium enhancement that do correlate with areas of amyloid involvement. This usually does not follow a predictable coronary distribution. It can be diffuse, or it might even be patchy, and it might even be patchier in patients with ATTR. Now, what is key and what is important is that this test is not amyloid type specific. So it's another test in our arsenal that is very useful, but also is not type specific. So it does build our index of suspicion. And then just for your interest, notice that MRIs can show amyloid involvement in other structures, the right ventricle and the atrium. So now this leads us to some amyloid type specific testing, and this will be covered in another talk, but we have free light chain assays, urine and serum immunofixation, bone scintigraphy, and tissue biopsy. So I want to thank you all for your attention, and this concludes this short discussion on building an index of suspicion for cardiac amyloidosis.
I strongly believe that building an index of suspicion is critically important, grounded in an increased awareness of amyloidosis red flags and risk factors. After all, suspicion is often what triggers the diagnostic process to begin with. We've seen that organizations like the American College of Cardiology have developed an expert consensus decision pathway on comprehensive multidisciplinary care for the patient with cardiac amyloidosis. And I suspect that other organizations may very well follow. And this is great. But let me say again, being suspicious can be what starts the diagnostic process, after which guidelines such as those from the ACC can then be utilized. Also, in a future episode, Dr. Groden will take discussions from this episode and move us forward through the diagnostic process for both AL and ATTR cardiac amyloidosis. I hope you enjoyed today's episode. If you'd like to watch Dr. Groden's video, please visit Mackenzie's Mission Education Hub at mm713.org. Thank you for listening to the All Things Amyloid podcast. If you find our podcast informative, please follow and share it with others. If you want to learn more about the work we're doing at Mackenzie's Mission, please visit mm713.org. We'd also like to thank AstraZeneca Pharmaceuticals, Alexion Pharmaceuticals, Alnylam Pharmaceuticals, and Bridge Biopharma for their sponsorship to help raise awareness about amyloidosis. We hope you stay tuned for future episode drops. Thanks for listening.